Test 1, 2.
Ja, of 2 dan later. Maar we gaan eerst al die presentaties doen. En dan questions and answers na de presentatie.
Ja. En heb je al iemand voor de microfoons meegebracht?
Nee, eigenlijk niet. Maar jij kunt dat doen.
Dan we even voor de andere microfoon plaats en dan die headset.
Oké.
Dat is niet zo heel praktisch.
Ik kan batterij wisselen van de headset met die andere microfoon en er 2. Ik zal het zo doen. Oké. Ja, excuseer.
Oké. Ja, maar dan kunnen we daar ook gebruiken. Kunnen we dat halen. Ja. Ja.
Ik zal mijn achter staan en dan heb je maar een kleedje en dan zet je maar aan met de
Ja, maar ik ga en dan ga je
Test 1, 2.
Dankjewel.
Ja. Of zo. Ja. En die zitten al allemaal achter elkaar. Je moet niet je eigen ding open doen.
Nee, dat is
Of
perfect.
zo, hè.
Ja. Kijk.
Ja.
Ook.
En zo, ja, daar weet ik eigenlijk. Of met deze gaat het ook, denk ik.
Oh,
Ja,
dat is
met
nog
de
beter.
grote.
Ja.
Ja. En terug. En daar.
Ah, dat is echt zo.
Zie je dat al?
Ja.
Ja.
Ja. Dus met de grote.
En daar weet ik niet wat dat is.
Nee.
Ja.
Dus met de grote is
Met de
volgende.
grote, ja, is volgende. Met
En
de kleine terug,
terug.
mocht je te
Ja.
ver gaan of
Oké.
zo.
En dan deze is als je iets wil, maar dat
Ja.
gaat niet nodig zijn.
Ja, oké.
Tof.
Hopelijk werkt het dan ook nog.
Dat is altijd met techniek, hè?
Ja,
Echt waar. Dan denk
en
je,
ik ben
heb
ook zo
alles gecheckt.
helemaal niet
Ik
goed
ook
in
niet.
die dingen.
Ik
Dus
ook niet.
ik
Je zou denken van, maar nee.
ik heb het dan
andere dingen.
de freeze. En help, kan iemand helpen?
Oh, ja. En dan gewoon, Oké. Ik dacht,
Fight, flight of freeze.
Ja,
Dus
dat
ik
zou
snap
gewoon,
niet.
of flight. En straks is daar een momentje om, nee, dat is het.
Nee, dat staat nog zo, want we gaan, om die tijd beter te kunnen bewaken, gaan we eerst alle presentaties doen en dan questions and answers. So everybody can ask
It's good.
a question. Huh?
Ja.
So,
I'm glad to hear
Ja.
that.
okay.
I'm sure. Well, I'm glad you're back. You're back at it. Yeah, I guess you're part of it. Oh, great. Okay. Yeah, I'm fine. Oh, you can. It's going well. I mean, right now, it's just so applying for a lot of different grants. Yeah, I did that. First of all, I don't similar to that. I don't know. But yeah, that one. Yeah, we'll see. You know, you toss it. Why? Nice to see you. It's actually like Yeah.
Because you can either do it with the keys,
Just go ahead.
or you have here the
okay.
pointer, the big one. You go forward,
Yeah. That is already marked. Okay, that's fine.
Huh?
It's so easy. Huh?
and like if you want to, that would be the pointer, but I don't think you will need it. Huh?
Okay.
So yeah. Wat moet ik dan hier doen? Staat aan. Okay, hello everybody. I think we would like to get started because we have a very full program, and so not to have a delay already from the beginning. I'm very happy to see so many of you today here to this seminar on mental health and migration, which is jointly organized by us, by ITM, but also by the University of Antwerp, by Migloba, and you will hear a little bit more in a few minutes about this network. So let me present myself. My name is Christiana Nöstlinger. I'm a psychologist and also social scientist here at ITM, and I work in the field of sexual health and HIV prevention at the HIV and Sexual Health Research Group. I will also chair the first part of this seminar and do the timekeeping. So as some of you may know, and I also see some faces of people who have actually been here with the very first seminar, which we organized in 2019 to put migration and health more generally on in the picture and on the agenda a little bit more. At that time, this was co-organized between us and CEMIS, also from the University of Antwerp. And it was actually already during the discussions that we had at this very first seminar that mental health was put forward as a kind of priority need of migrants, which of course is a very heterogeneous term. It includes many different groups of different people, with maybe special attention to also asylum seekers and refugees. So 4 years later, and also after the COVID epidemics, which have taken their toll not only on physical health, but also really very much on mental health. Today, we want to take a closer look on mental health and mental well-being of different groups of migrant populations in vulnerable situations. So I would just like to say, as I come from the sexual health field, we have always for already quite some time considered mental health as a determinant for health outcomes in both HIV prevention, but also how people adhere to HIV treatment and these kind of things. But of course, mental health is much more. It's a health outcome in itself. And it's also a human right, actually, which is why we have also chosen one of the pictures of the Global World Mental Health Day, which is on October 10th. So in this spirit today, we want to focus on public mental health questions and approach it from both the theoretical side as well as maybe the practical side. So I'm very happy to have to have invited and that people have accepted to also present how they work in the front line and to present some good practice examples. But before we get started, I would just like to quickly take you through the program. But it's very small, of course, but I'm not going into detail, just to basically say we have like 2 blocks. We will have a coffee break in between. And in the first block, we will focus on what cultural diversity means or doesn't mean for mental health and mental well-being. And we will have some examples of people working especially with asylum seekers and refugees. And in the second block, we will focus on interventions. So what is known, what works, again, followed by some best practice examples from the Belgian context. And in order to keep the time, we would like to have the presentations first, and each block will be then followed by a questions and answer session. So please keep your questions until the end of each block. And then I have a few things just to announce in terms of housekeeping items. First of all, I would like you to switch off your phones, if that is possible. I apologize for not having served coffee at the beginning, but there will be coffee in the break. And I would also like to mention that we will record this session through Zoom, and the recording will be made available to interested people. So if you don't agree to recording, we have asked all the speakers who agree to recording and dissemination. So just that you know. So let me get started with the introduction. So first, I would also like to give the floor to Milena Belon. She is an associated professor at the University of Antwerp at the Department of Sociology, and she's the coordinator of the MiGloba network, and she will introduce this network to you, but she is also in her research capacity an ethnographer and has conducted extensive research in different African countries and also in Italy. And we are very happy to be able to co-organize this seminar with you. So please. And I will set up this for you. Okay. Yeah.
Yeah, thanks a lot, Christiana. It was actually a wonderful start of my adventure as a coordinator of MiGloba to co-organize this event together with Christiana, but also with Hanne Alpers that is going to speak after me and has been so kind in assisting and co-organizing with us this event. So yeah, as Christiana told you, I am a professor at the Department of Sociology at the University of Antwerp, and my focus for the last 10 years and more has been on migration and global mobility. I'm now coordinating a network that is called MiGloba, and this MiGloba tries to build on the legacy of SEMIS. You might have been familiar with this name before. SEMIS was the Center for Migration and Intercultural Studies, and MiGloba is somehow the inheritor of SEMIS. We want to create an interdisciplinary space for collaboration and exchange among migration scholars within and outside the University of Antwerp. So the idea is really to be able to create a platform for people to collaborate on these topics, both for academics, but also for people from the field. This is a very important part of our vision. And also to try to disseminate the kind of knowledge that is created in the ivory tower and make it useful for people outside it. Oops, sorry. So who are we? We're a bunch of lecturers and also researchers working in social sciences from the many different departments, but not only, people also from humanities and law and health sciences joined Migloba, and they make this network rich in terms of collaborations and also initiatives that we want to bring forth. Iman Bendra, Rose Derricks, and Giovanni Pena have been the doctoral and postdoctoral researchers that are helping us in this endeavor. Yeah, and we focus on 4 big research areas, let's say diversity and civil society, social inclusion and migrant population, global mobility and governance, media and mobility. And for us, let's say the work on health and migration is somehow included in the research area on social inclusion and migrant population. What do? We've organized event, and we want to keep organizing events. We want to kind of enable and encourage networking among academics, again, within the University of Antwerp, but also very much outside it, also with the civil society. And we carry out outreach and dissemination work. Because I don't want to take too much time, I just would like invite you to check our website out and also to check our Facebook page. And if you're interested to get in touch because you're working on the topic in the many different kind of sub-thematic areas that we are also touching upon, please feel free to contact us, to contact me. And I mean, it would be nice to collaborate together. So thanks again to Christiana and ITM for hosting us and the event today. And then I let Christiana again here to introduce the next speakers. So thank you for being here.
Okay, so I would like to introduce the first speaker. It is Hanne Appers. She's a PhD student at the University of Antwerp at the Center for Population, Family and Health, and she's also a member of the Migloba network. Her background is in psychology and anthropology, and she's currently finalizing her PhD on mental health understandings among Eastern African migrants living in Flanders or in Belgium, I don't know. In Belgium, yeah. So she's really well placed to give an overarching introduction to, first of all, shed light on the mental health burden among migrants, but also she will elaborate on why migration is considered a social health determinant for mental health and how mental health is actually culturally defined. So the floor is yours.
Okay. Good afternoon, everyone. I will move to my starting slide. Nice to see you all here. I will give indeed a general introduction on the topic of today, and I will try to answer the question of today: why should we focus on migration and mental health? And I will do that by pointing out 3 important, I think, key points. The first one being that prevalence numbers are higher among migrants, prevalence numbers of mental health issues, of course. The second one being that migration is a social determinant for mental health. And the third one, mental health understandings are culturally defined, as Christiana already mentioned as well. So let's move to the first point. Prevalence numbers of mental health issues are higher among migrants. I'm going to present some review studies in the next slides. I don't know if everyone has a research background, but review studies are studies that actually collect multiple studies, assess them and analyze them. And from these collection and analysis, in the next review studies that I will present, they also calculated an overall prevalence rate for particular mental health issues among migrants. So the first review study that I want to present is a study that was published in 2020 by Blackmore and colleagues. They selected 26 cross-sectional studies focusing on the prevalence of mental illness in refugees and asylum seekers, so this particular target group. And they calculated an overall prevalence rate of depression of 31% among this target group. Anxiety issues, they calculated the prevalence of 11%. And for PTSD, post-traumatic stress disorder, they calculated a prevalence of 31%, which they found and concluded that for depression and PTSD, these are higher prevalences than compared to general populations. And to make this comparison, I also added the latest Belgian prevalence numbers that I could find for the same mental health illnesses. And as you can see, indeed, for depression and PTSD, the numbers among refugees and asylum seekers are way higher, except for 2020. But of course, then there was the COVID-19 crisis. So then also the prevalence numbers of mental health issues among Belgians were higher. The second review study that I want to highlight looked into the prevalence rate of depression among migrants in general. So they didn't look at one specific target group, and they looked at 25 cross-sectional studies. They also did the global search. In the previous review study, it was also studies from all over the world. And in this review study, they calculated an overall prevalence rate of 15%, so still higher than the prevalence rate among general population in, let's say, normal times, non-COVID times. And from these studies, they also concluded that newly arrived migrants were apparently more vulnerable to develop depression. And then a last review study that I want to present looked at adult irregular migrants, so those migrants who don't have a legal permit to stay, a residence permit, or who were in this procedure but did not get a permit but decided to stay in the countries anyway, so who move outside the regular migration patterns. And these authors looked at specifically Europe, and they selected 8 cross-sectional studies. But in this review study, they didn't calculate an overall prevalence rate, but they looked at the different prevalence numbers, and they saw that actually they ranged quite a lot. As you can see, for depression, it starts with 8% up to 86%. For anxiety issues, you start at 3% up to 81%. And for PTSD, from 3 to 57%. And although these numbers are very different and ranging a lot, they concluded that in the majority of the studies, there were still higher rates for depression, anxiety, and PTSD compared to the general population. But I presented this review study as well because I think it points very apparently to limitations of prevalence studies. And I think there are 2 important factors that we have to consider when we look at limitations. The first one is that very different methodologies, different tools are being used among all these prevalence studies. So that makes it difficult to compare, especially diagnosing tools as well are debated in the field because they're often developed among wide populations in a wide context. So the question is if we can also use these tools, these questionnaires among migrant populations, although there are some questionnaires that are being culturally validated, as we say, there is still this question, do people understand the same terms, the same things that we use to, or the researchers use to describe mental health? A second factor that influences this very variety of prevalence numbers is, of course, that researchers focus on different target groups, as in my previous presented studies as well. Some focus on asylum seekers, some focus on irregular migrants, some focus on migrants more in general. And they also use different definitions of migrants. So what is a migrant actually? Is it someone that recently moved to another country, or is it someone that is already living longer there? Do we still consider him or her as a migrant? Do we look at second generation migrants? So the countries of origin, also how long people are staying in the country of destination. These are all factors that make that prevalence numbers can vary a lot. And related to the diagnosing tools, of course, also that we use different definition of mental health disorders. What do we call a depression? So, well, prevalence studies are very important and can give an indication of the scale of the issue. I think we also need to look broader than that, not only at the numbers, but also have to look at why are migrants vulnerable. And then I come to my second point, and that is that migration is a social determinant for mental health. For those among you who didn't hear about the term social determinant yet, this refers actually to the social and economic conditions that can have an impact on the health outcomes of an individual. So every one of us is exposed to social determinants. And as you can see in the figure here, these determinants can be found on different levels in the society, in the socio-ecological context that an individual lives. So starting with, of course, the fixed factors such as age or sex, then going to individual lifestyle factors, the social and community networks that an individual is finding himself or herself in, living and working conditions of the individual, and then the broader socio-economic, cultural, and environmental context that we are all living in. So policies, also how health systems operate, the access that you have to health systems. These are all determinants, all influences to an individual's health status. And IOM, so the International Organization for Migration, actually states that migration cuts across all these levels through all these social determinants of health, and they indicated some examples. These are directed more to general health, but I think you can also apply them to mental health. And not only does migration cut across all these different levels of social determinants, but of course it's also relevant in all different stages throughout the migration, which this figure, I think, nicely puts forward by showing the risk factors that are associated to every single stage of migration. But with this slide, I want to make some remarks as well, because this slide can make it seem that there's actually one single trajectory that migrants undergo, but of course that's not true. There are many different trajectories that migrants can have. Some people move from one context immediately to another context. Other migrants move in different steps, living in different countries, living in different situations. So at all these different contexts, there are different social determinants at stake. There are different risk factors at stake. This figure is also specifically directed to asylum seeker and refugees, but of course, these are not the only people, only migrants that are vulnerable to develop mental health problems. If we consider, for instance, international students or experts, if they move from one context to another, they can also be confronted with risk factors that are mentioned on this slide. For instance, social isolation, the homesickness, the loss of family and friends networks, but also discrimination and racism. And I think that is something very important. So I want to really point to this influence, because I think we cannot underestimate the influence of racism and discrimination. So that's why I put these two quotes on this slide, and I will let them read you for a bit, and I will take a sip of water. So I think that these two quotes really illustrate why racism and discrimination can have real effects on not only mental health, but on physical health as well. And I really want to point also to the second quote that is also mentioning the fact that it doesn't have to be a direct experience. It's not only if the person him or herself experiences this racism or discrimination, but it can also be indirect through the media, as is mentioned here, but also along generations. If parents are exposed to racism, they can transmit this mental health effect to later generations. And of course, it's not only limited to migrants, but to people having a different skin color than the general population who have been confronted or can be confronted to racism and discrimination. And this transmission can also be the case in migration. The effects of the migration trajectory can also be transmitted throughout generations. The trauma can be transmitted. So that's something that is also important to take into account. And the last thing that I want to point out in this slide is what I think is very nicely done by the authors, is that they also point to protective factors of migration, because I think we have to be careful to not always depict the migrant as a vulnerable person. Also in migration, there can be very positive sides. People can move to safer places. People can have a very strong resilience. There is even research showing that migrants who have experienced very much of these risk factors even build more resilience or stronger coping strategies because of their experiences. So I think it's very important to also focus on this side of migration. And I think it can also maybe be informative for if we develop, for instance, prevention programs, or if we want to work with a migrant patient to look at these protective factors, to look at resilience, and to look at good coping strategies. So then I will come to the last point that I want to make today. Mental health understandings are culturally defined. And to really understand why there are different perspectives on mental health, we have to look, of course, at the history. And we see that in global North cultures, in common, there is this mind-body dualism. These ideas were already present in ancient Greek Empire with the philosophers Plato and Aristotle, but it was René Descartes who really built this idea and put out this distinction between mind and body there. And from his ideas, this modern medicine developed, differentiating between mental and physical health. While in global South cultures, this distinction was less prevalent, and we see more holistic perspectives on health, also having influences from religion, from nature, and the spiritual world. And of course, these main ideas, these ways of thinking that we can see in these cultures also have an influence on how healthcare systems and practices were developed and evolved in these cultures. Of course, I'm putting it very superficial here. It's more diverse than just this distinction between global North and global South. But I think it's important to have this in the back of your hand to understand why people look differently or understand mental health differently. And if you want to learn more about it or read more about it, I really recommend this book of Simon Fernando, Mental Health, Race and Culture. It's a really informative and very critical book as well. And then I want to end my presentation with this quote of Arthur Kleiman, who is an anthropologist and a psychiatrist, and who really focused on the influence of cultural understandings in health and illness. As he says in this quote, illness is culturally shaped in the sense that how we perceive, experience, and cope with disease is based on our explanations of sickness, explanations specific to the social positions we occupy, and systems of meaning we employ. And I think that is equally true for the patient, but as well for the healthcare provider. So that's something important as well. The healthcare provider also lives in a certain culture, also has this cultural background, and this also plays a role in the healthcare practice. So a healthcare provider should be aware as well of his own cultural background and how that maybe plays a role in how he practices or she practices in their daily care. And then it's of course very essential to know that cultural understandings are different, but we have to be careful to not essentialize culture and to not look only at the person as he or she is his culture. Of course, there's also influence of personal experiences, of the social networks, of the socio-economic background, educational background, also of globalization, social media, internet. So we have to be careful to not essentialize culture, but at the same time be aware that cultural aspects can play a role. And with that thought, I want to end my presentation. So I want to thank you all for your attention. If you have questions and remarks, there's the Q&A at the end of the session, but you can always also send me an email. Thank you.
Okay, thank you, Hanne, for this interesting presentation, but also for being perfectly within the time. So now I would like to invite Lucas Klaus. He's a resident psychiatrist at the VUB, is at Brussels, and also doing his PhD at the University of Antwerp. His research focuses on how to screen and diagnose mental health conditions, I think especially among asylum seekers and refugees, but also if and how culture and context can be figured into such screening tools and how they could potentially help improving the healthcare for this population. So I think in your presentation, you will mainly focus on barriers to mental health care, but also mention specific themes such as migration-related stressors, such as, for instance, acculturation stress. So please come up here and I wanted to, yeah, here. So you can go forward with this if you want.
So, hello everyone. I'm Lucas, and I'm going to tell you something more about asylum seekers and mental health, because, yeah, the number of forcibly displaced people has been increasing progressively in recent years, and during 2022, more than 30,000 people applied for asylum in Belgium. Refugees and asylum seekers may have to cope with different adverse life events, such as separation from their family, very difficult migration journeys, lengthy asylum procedures. And a big proportion of asylum seekers is therefore at risk of developing mental health problems. And the recent meta-analysis where Hanne has been talking about, they did also a subgroup analysis for asylum seekers. And in that subgroup analysis, we see that, yeah, more than 25% of asylum seekers suffer from a post-traumatic stress disorder, more than 30% of depression. And as Hanne already said, the prevalence rates, they vary greatly, not only because of the methodological differences, but also because of the differences in risk factors and protective factors throughout the migration cycle. And that's a bit the same figure that Hanne has been showing. And I wanted to show you this figure again, because I think it's very important to realize when working with asylum seekers, that it's not only the migration phase that can be stressful, but that it is everything that comes before and also afterwards. And I'm going to illustrate the importance of those different critical time points in migration with a short case description of Mohammed. Mohammed is 20 years old and he comes from Palestine, Gaza. He was always worrying in Gaza and uncertain because there was a constant risk of rocket attacks. He often felt powerless, and because the situation was really behind his control and he lived in constant tension. Mohammed, he was also physically abused and tortured because he protested against the construction of a tunnel in Palestine. And because his father was member of the Mahmoud Abbas party, he was even more at risk because of Hamas domination. He had to leave many dear people behind in Gaza when he left, including his mother, father, brothers, sisters, and even his wife, which made him very sad. And the migration process to come here was really difficult for him. It was also very hard for him to talk about it because it brought back very difficult memories. He stayed a while in Sweden, but there his asylum applications were always rejected. And then he came to Belgium, where he had to sleep on the streets in Brussels due to a lack of shelter. And this caused a lot of stress and anxiety for him. And now he's having a very hard time waiting for a decision in his asylum procedure. He also struggles with having to share a room with 6 people in the asylum center. He is afraid of ending up in the street again, of being expelled. And he stresses to me the need for stability and treatment for his physical and mental health. And despite the high prevalences of mental health difficulties and numerous risk factors, the use of mental health services by asylum seekers seems quite low relative to the need. For example, Dutch researchers show that only 8.8% of Iraqi asylum seekers with psychiatric disorders had contact with mental health services. A notion of possible barriers to mental health care is therefore necessary. And based on a literature review, we structured the barriers to mental health care for asylum seekers around following 6 themes. First, we have the lack of knowledge of the healthcare system and of mental health, language barriers, expressions of psychological distress and illness explanations, expectations about therapeutic relationship and treatment, lack of trust and stigma, and structural difficulties. And I will go through these with you. The first barrier is lack of knowledge of healthcare system and healthcare rights. Both asylum seekers and care providers often lack knowledge about the rights or the procedures to access care. And asylum seekers also experience it as challenging to navigate the strange and complex healthcare system. Since they are often part of closed social communities, it's hard for them to find information about mental health care within their primary support group. And healthcare providers, they have difficulty to understand what the specific needs of asylum seekers are. A second and important barrier are the language barriers, one of the main challenges. And we know that when communication between asylum seekers and caregivers, it's difficult. 2 to 3 times fewer symptoms are reported. And despite this, only 53% of European mental health services for refugees and asylum seekers has interpreters. And interpreting by family members doesn't seem to be a good solution for this issue. Working with professional interpreters helps to optimize the problem understanding, to build a trusting relationship and increase patient engagement in mental health care. However, in Belgium, stakeholders report a shortage of interpreter availability, and extending the support of interpreters could offer improvement in the short term. A third barrier is, the expression of psychological distress and illness explanation. And the population of asylum seekers is a very diverse group with very different cultural backgrounds, and that has an important influence on their attitudes towards mental health. In mental health care for asylum seekers, it might be challenging to distinguish between psychiatric disorders and symptoms of temporary distress. A Moroccan asylum seeker, for example, told me that his caregivers, they thought that he has serious mental illness because he talks very quickly and loudly when he's stressed, while for him it's just a way to express that he is really not feeling well at the moment. In addition, it can be difficult to recognize certain manifestations of psychological distress, such as somatization. In my own research, working with young asylum seekers, they often complained of zaretankwali, which was the feeling, a suffocated feeling or short of breath, in Pashto. And when I explored this complaint further, this mainly turned out as experiences of tension, stress, anxiety. Also, cultural confirming reactions are sometimes wrongly classified as pathological. For instance, hair pulling can also represent a cultural mourning disorder, a mourning ritual, not a disorder. And patients may also have a different understanding of mental health. For example, see mental health as spiritual well-being. And also other explanatory models can be used, sometimes religious or supernatural. For example, the conviction of being possessed by spirits. And this might create a feeling of mismatch between the healthcare system and the need as perceived by the patients. Asylum seekers, they experience the need for attention to their habits, to their explanations, and as caregiver, I think it's important to recognize these beliefs as legitimate and meaningful. Fourth barrier are the expectations about therapeutic relationship and treatment. A patient's cultural background also impacts their expectations of mental health services, and they might have high expectations of clinicians. For example, a lot of the participants of my research, they expected me to be able to change their living conditions or their asylum procedure. But there may also be differences in expectations regarding suggested treatment, such as opting for medication instead of psychotherapy. Of course, a trauma-sensitive approach working with asylum seekers is very important, and culturally sensitive treatment methods may also have a positive value for asylum seekers, while Western methods like psychotherapy might sometimes be a bit more difficult. And treatment focused on functional recovery, what would they like to be able to do, would better meet their needs than treatment focused on emotions. How are you feeling? A fifth barrier, important barrier also, is a lack of trust and stigma, because asylum seekers, they often lack trust in public organizations, partly because of their own experiences of trauma and discrimination. And these undermine trust in a foreign healthcare system and sharing of sensitive information. And this trust towards healthcare providers can be caused by fears of that they care providers are out for their money, or by the fear that they would pass information to public instances or loved ones. And the distrust can still be reinforced by the fear of not being able to pay the healthcare provider for being sued for it, by not feeling understood, or by receiving unclear explanations. And among many participants, I encountered anxiety about opening up about their stories, doubting whether caregivers would communicate information about them to legal instances. Public opinion and migration policy may also affect asylum seekers' mental health. An anti-immigration rhetoric can really induce avoidance of healthcare by asylum seekers and negatively impact their attitude towards or interactions with caregivers. And stigma also forms a significant barrier to psychiatric care provision. Not only experiencing mental health problems, but also engaging in care provision can be very stigmatizing for asylum seekers. And many of our participants were afraid that roommates would gossip about them or make fun of them when they shared their difficulties. And to avoid stigma, it's important to reach out to asylum seekers. Involvement and a holistic view of the provider towards asylum seekers can help to build trust and more positive relationship in host countries where negative societal attitudes towards asylum seekers exist. And the last barrier are the structural difficulties, because financial constraints and precarious living conditions, they can force asylum seekers to prioritize basic needs over mental health. And this leads to overconsumption of emergency care. This leads to a lack of continuity of care. And the offer of preventive healthcare is also often limited. And sometimes asylum seekers also report that they stay healthy by staying away from doctors. There's also a lack of adapted care. And this leads to overcrowding or long waiting lists, and mental health care for asylum seekers often is not a policy priority, as it is often already inadequate for the general population. And due to poor assessment of asylum seekers' mental health care needs, their needs remain unclear to policymakers. And also in Belgium, there is a major lack of mainstream mental health care for asylum seekers, and more structured training for caregivers could already partially address this issue. We can conclude that although psychopathology is common among asylum seekers, their use of psychiatric care remains very low, and several barriers impede access to mental health care. We need to pay more attention to culture and to context to lower these barriers. And for our research project, we wanted to investigate whether the cultural formulation interview could be helpful for this purpose. Something more about the cultural formulation interview. It's a standardized 16-item questionnaire designed to focus attention on patient's perspective, cultural, social context during a psychiatric assessment. It covers 4 cultural domains: cultural definition of the problem, their perception of cause, context, and support, cultural identity, and the factors that impact help seeking. Implementation of the cultural formulation interview has already been evaluated in different populations and different countries. However, today we lack knowledge on the impact of the cultural formulation interview on clinical outcomes, and also its use in asylum seekers has not been investigated yet. Laura is going to tell something more about this, working with the CFI after my talk. But I shortly will share something about my research, because with my doctoral research, I want to evaluate the value of the CFI in mental health care for asylum seekers. And since the start of my PhD, I've done a bit more than 60 CFIs with asylum seekers. And to finish my presentation, I wanted to share some impressions of that work, because I think that cultural formulation can be, for different reasons, valuable working with this population. And the first theme is the cultural identity, because asylum seekers may have a particularly nuanced background in terms of cultural identity. Their cultural identity is, of course, linked to their country and region of origin, but the link can be very complex due to their ambivalent relationship with the country of origin. And they may also have a more fluid understanding of their identity impacted by their migration, which differs from the initial assessment made by the caregiver, which is based on skin color, country of origin, the name. And cultural formulation can help picture out what asylum seekers experience as their cultural identity, and how this experience of cultural identity interacts with their experience of mental health. In addition to cultural identity, they also may have a more culturally determined understanding of the causes and context of their problem, and different causal explanations can be put forward, and context can also significantly impact their experience of mental health symptoms. For example, many clinicians, they link psychiatric symptoms with the histories of traumatization of forcibly displaced people, although the patients themselves, they link the difficulties more with their present social and juridical situations, while experiencing a lot of nostalgia for their past life. And this is nostalgia, I think, a strong attachment to the past. It can also be a key feature of what we call cultural bereavement, and cultural bereavement is described as that profound feeling of grief and loss that arises from having to leave one's culture, one's country behind, in particularly when migration is very sudden, and that loss is associated with an intense feeling of rootlessness, especially when migration is forced. And culturally bereaved people, they might meet diagnostic criteria, PTSD criteria. However, symptoms of bereavement and grief, they are not forcefully pathological, and they can be adaptive. And clinicians should separate maladaptive signs of pathology, like re-experiencing the past in PTSD, from more adaptive signs of a culturally normal relationship between the person's past and present life. And then we're talking about feelings of uprootedness, bereavement, and grief. And in this perspective, symptoms, they can just be a normal reaction to a very abnormal context. And cultural formulation can help to get a picture of this abnormal context and to evaluate feelings of bereavement and grief appropriately. And finally, when working with asylum seekers, also factors that influence current health seeking and care should be considered. Discrimination of patients in mental health care remains a big issue. Asylum seekers may be considered as difficult or challenging patients, and therefore they might want to distance themselves from their culture to receive regular health care just like everyone. And besides, the discrepancy between the type of health problem and the type of care has been described. As asylum seekers are often referred to non-psychiatric care and specialists, they're not getting adequate care. And clinicians should be aware also that psychiatry has its own cultural views, including the conviction that treatments such as medication and psychotherapy work and have a positive effect. At the same time, clinicians should pay attention not to medicalize human experiences, which can lead to reduction of this experience of the asylum seeker and prioritize a single diagnostic category, such like trauma, and neglect the current factors of suffering. And cultural formulation could help to bridge the cultural differences in the relationship between the individual and the clinician. Yeah, there is no greater sorrow on earth than the loss of one's native land. And with those famous words of Euripides Medea, the United Nations accurately illustrated the state and suffering of asylum seekers. And I think that it's important to do our part as caregivers and clinicians, researchers, to ease the suffering of this vulnerable population.
So next, I would like to invite Laura van de Vliet. She's also a psychiatrist at St. Alexios Psychiatric Hospital in Grimbergen. And in addition to her work there, she's also involved in psychiatric care or responsible for that specific project, psychiatric care for asylum seekers through POSA, which would mean psychiatric support and care for asylum seekers in a home-based delivery format. So within this framework, I think you are also involved in some research, which you will present, but you will mainly talk about or describe the services for asylum seekers, and you will also talk about how intersectional vulnerability factors, how they impact on the mental health of asylum seekers. Thank you very much for being here, and the floor is yours. You can go forward here with that big one.
Okay, perfect. Hola. Yes. All right, good afternoon. Thank you for inviting me here today to talk about the work we do. As said, I'm Laura. I'm a psychiatrist working in Grimbergen. I will try to present to you today a little bit what we do in POSA. POSA is our, it started as a pilot project in 2016, where we try to provide psychiatric care for asylum seekers in cooperation with Fedazil. And I thought I was going to be a bit too, talk too long, but the two speakers before me, they mentioned already some points that I wanted to mention, so that it'll make it shorter, and I'll skip a few slides probably because of that. And I will zoom in onto the barriers that we experience in our clinical practice. Lucas has been a bit more general. I'll try to focus on what we personally experience in what we do, and I'll try to talk to you a little bit about how we try to overcome these barriers. So POSA, as pointed out, it's a Dutch abbreviation, and it means Psychiatrische Ondersteuning en Zorg voor Asielzoekers aan Huis, which means in fact that we indeed provide inpatient but also outpatient care, and we try to have a more outreaching way of working, or as much as we can. So we started in 2016 as a pilot project, and since a year we became sort of a center of expertise as we obtained a more structural cooperation with Fedazil to further develop the clinical work we do. We provide inpatient care, which means a residential admission into our hospital, but also outpatient care, where we provide ambulant or consultations in our hospital, but also we go to the centers and provide care over there. This is for adult asylum seekers, so we don't see minors. The idea is that it should be asylum seekers with severe mental illness, but we see that it's not always like a severe psychiatric diagnosis that we find when we go into conversation with them. And we work for Region North, which means that it's all of Flanders, but not the south of Belgium at the moment. That's a very small but highly motivated team. It's me as the psychiatrist, but I also have two psychologists. We have a coordinator, a social worker, and an occupational therapist, who are all very eager to try and provide the best care we can. In our inpatient setting, people are admitted to a psychiatric ward in our hospital, which means that we don't have a ward specifically for asylum seekers. So people are admitted, but they kind of mingle with the other patients that are admitted to the ward. And that's both good and sometimes also difficult, but I'll come back to that later. We try to provide as well mental aftercare when they are going back to the center, and we try to bridge also, or to make the bridge with a regular care network afterwards, or when they get their papers, for example, we try to make the bridge with the regular network where they start living from then on. And in our outpatient setting, like I said, we do consultation and also more outreaching work. We also try to coach the medical service, but also the social workers in the centers to sort of cope with the difficulties that those patients sometimes present in terms of behavior, in terms of living in a collective living situation, which isn't easy. How to register, maybe for some of you, can be important. It's always through the medical coordinator of FEDASIL. So, and then we kind of check what kind of care we provide, because we do believe that there's no one size fits all approach. We really try to provide care that is, or that fits to the person and his or her unique needs that we have in front of us. Okay, in those 3 years that I've been working for POSA up until now, as Lucas pointed out, I also kind of experienced that asylum seekers are often left behind when it comes to mental health care here in Belgium. And I think that's especially hard because it's a group that is already very vulnerable when it comes to discrimination based on their fragile social status as stateless people, but also, you know, they experience racism by religion, by skin color, and so forth. And on top of that, as Lucas already pointed out as well, they are very vulnerable to trauma and to mental health issues. And intersectionality is a concept that kind of illustrates the snowball effect that a combination of those vulnerabilities has for those people. So intersectionality actually describes the way in which different systems of inequality based on gender, on race, on sexuality, and so forth kind of intersect and reinforce one another. And the idea is that therefore you must address those different inequalities in order to provide solutions. Not that you can provide solutions all the time, but it's not enough to address one of them to go forward. And I think that in this concept, there lies a lot of opportunities for us as mental health workers in the host country to create a more inclusive care system that that can provide specialized care for this group in need. Because I personally believe that mental health care for asylum seekers is in a way a specialized niche within the mental health care system. I think that it's very important to provide specific care adapted to their needs, but also that it needs specific knowledge about the background or the difficult sociocultural situation those people are in. So that's why I think this is a very important concept to think about. Now, the barriers we experience in our clinical practice, some of them have been talked about already. So I think language it's one of them, especially because people are admitted to our general wards in the hospital, where we have also group therapies, a lot of verbal therapies. It's not very easy for them to take part in that. Apart from that, we often see that our patients have complex traumas, and complex trauma or complex PTSD comes with a complex set of symptoms that can also mask other comorbidities. And so it's not always easy to provide correct diagnostics. the same time, we see that the lingering asylum procedures, the current shelter conditions provide often extra stress. And due to these conditions, there's a lack of basic safety, or like a sort of a lack of a safe base to start from when you want to build bridges and when you want to start therapy or start working on emotion regulation skills and so on. So it's not really easy, both on the terms of the diagnostics as on the terms of the further trajectory or the therapy you want to install. This brings us to the next part, where I'll try to focus a little bit on how we try to overcome those barriers in terms of cultural sensitive diagnostics. I think what's important to know that in essence, the work we do as mental health care workers, it's about meeting people, a meeting as a dialogue between two or more people, but people who are different from one another. And in this case, the cultural difference is added to the difference that we all have. Also with, general Belgian patients, I'm different in them when I see them, and it's also a meeting and you need to overcome the difference. But when there's culture, it may become a little bit, or in our head, it may become much more difficult, because then we might, or some people might back away, other people might rely on stereotypes and think like, whoa, but I know everything about this, when in fact they don't know anything at all. And in order to communicate in a culturally sensitive way, you can acquire sort of a set of skills to do this, which is called cultural competence. And I think that cultural competence starts with the awareness of what culture is, but also what it means about your own values, your own background, your own beliefs and identity. And being aware of your own cultural background and identity provides to you an opportunity to start building bridges to the culturally different other in front of you. Now, what is culture? It's a very difficult question. And to me, what is very important to realize is that culture, or the impact of culture on one's cultural identity, is often very invisible. We all think that we know, like, differences in food, in dress code, and so on. And we think we know everything about a culture, which is not. There's a lot beneath the surface about, more detailed attitudes, customs, values. And it's important to realize that you can only get to know that when you use a person-oriented approach, when you ask people directly about how they experience their own culture. Next to that, it's important to realize that what's already been said, but that our mental health care system is also a cultural system. It is based on Western standards or Western assumptions about what mental illness is about, what mental symptoms are about, symptom presentation is about. And so, as Lucas already pointed out, we have the idea that people of a different cultural background often somatize, and they might, on the other hand, have the idea that we psychologize. So it's very important to be aware of what side of the balance you're on to be able to go further. I think that in essence, what Lucas already said about explanatory models and what's been said about Arthur Kleinman before is that human beings, they use stories to make sense of life. And we do this in every domain of life, but we do the same when it comes to illness presentation. And that's where Arthur Kleinman introduced the term of these explanatory models, because these are actually the stories we use to explain for ourselves what we feel and why we feel this, what happened to us. And it's important to explore these explanatory models, because otherwise you end up in parallel conversations about the same thing. So in order to be able to meet each other halfway, it's first of all, important to know what your own explanatory model about a certain illness, symptom, or presentation is, but it's also important to make the bridge and to find out what other people believe about that. And again, as Lucas already pointed out, cultural formulation is a way to do this. So the fact that our mental health care system is a Western idea that already occurred to psychiatrists years ago when they were thinking about DSM and about psychiatric diagnosis, instruments they use, and where they found out that it's kind of, they don't really fit well with other cultural backgrounds. And so they thought, well, we need to pay attention to the importance of culture and context in the evaluation of psychiatric symptoms. And so we will introduce this cultural formulation and link to it the cultural formulation interview. It contains 5 topics, as Lucas already said. So cultural identity, but also the explanation of illness, the cultural factors that can both be stressors and supportive factors, and also the cultural aspects of a clinician-patient relationship. I will not go deeper into this because Lucas already explained it, but what I will do is I will try to illustrate the use of the CFI with a clinical case. This is the story of Enar. Enar is a Kurdic Syrian 28-year-old male asylum seeker who was referred to us by the center he was staying at that time, mainly because of difficult behavior. He was often, he had a lot of crisis moments. He was often very aggressive, which resulted in destruction of materials in the center, but also in physical fights with other people. So it wasn't kind of really doable in the center to, keep going on like that. On top of that, he had several disciplinary transfers already before. He had been granted asylum earlier in Denmark, and over there he'd had caused trouble as well. He had been admitted to a psychiatric ward. So it had been already a very long story. And when I saw him for the first time, I have to say that he was a bit, or he presented in a strange or a somewhat bizarre way to me. He wanted me to touch his head all the time because he had the experience that he had head injury before. He had been in a coma. He had survived a car crash, and there should be a scar on his head. I didn't see anything, but it was a bit of a strange encounter, I have to say. He was very agitated. He was disorganized, chaotic. It was not easy to get a straight line in whatever he was telling me. On top of that, he told me that sometimes he used marijuana to calm down because it was the only thing that could calm him down. And then he told me some strange things, like when I was a baby, I was born with long hair. There was a car that hit me, but I survived. He seemed to have the impression that he was a sort of a miracle man. And he also told me that he didn't talk up until the age of 11 years old. So yeah, I asked myself, what's going on here? What is this? Because a lot of the behavior he displayed could perfectly fit into a complex PTSD. But on the other hand, all the strange things he told me, and the disorganized behavior, and the chaotic and hyper-aware presentation, a little bit paranoid, it could also fit into a psychotic episode, and treating both of them, you do in a very different way. So I was a bit at loss. And that's when the cultural formulation interview and Lucas stepped in. And so Enar explained to us when we asked him about his own definition of what was going on and of the problems he experienced, he told us, like, I have so many problems and it's so hard to handle. There's the asylum procedure, there's the trauma I had in my past, there's the experience I've had in Denmark, and it's all too much, and I can't get grip on it. I don't know what to do with it. And I'm losing control, and I don't want to lose control. He also told us, like, I'm not able to share this with other people because, one, they cannot help me, and two, I don't want to put the burden on them. So I don't want to talk about what I'm feeling. He also elaborated a lot on his need for safety, for stability, the idea of being rejected everywhere. He had a great sense of injustice, not only for himself, but also for other asylum seekers in who we knew in the center, more in general. He talked to me about war in Ukraine as well. And I mean, he had this big sense of injustice. And then he said, like, I'm from Syria, but I'm also a Kurd. And I don't know how to say it in English, Alawite. It's a part of Islam that's not always accepted within the general beliefs of Islam. So he said, like, I've been rejected all of my life. I've never had a proper identity, and I've never been recognized for who I am. I've always been the one who was pushed aside, and that's who I am. Being pushed aside is who I am. So for him, obtaining papers here in Belgium was like the only chance to control things and to find a safe haven. And that's why he put so much importance into that injustice that he experienced. When asked about explanatory models, how would he explain his symptoms? How would he say what caused what he was feeling? He told us, like, yeah, there's a lot of racism and discrimination, and actually I should be able to put that aside and not to react to it all the time. But I feel like a kettle and the water's boiling and it wants to get out and it can't get out. And I'm so exhausted because I cannot control it on my own. He also said he was very disappointed and scared of being rejected again here in Belgium. And so in the end, the information of the CFI, for me, it provided a broader picture of the context he was in. And this idea that he had psychotic episodes, I kind of could skip it completely because he was absolutely able to talk about what's going on. He was able to mentalize about the problems he had, about the emotion dysregulation he experienced, but he just couldn't control it because of the basic unsafety he still experienced and still had around him due to his insecure asylum procedure. And so I personally think that this case not only illustrates how the CFI can help you in your diagnostics, but how it illustrates also how this complex interplay of cultural background, current social situation, discrimination leads to an even greater burden and complex display of symptoms and of set of behaviors, and how hard it sometimes is to disentangle it and try to find a way to work through it. I'll briefly say something about our experience with therapy. So I think the main message here is that I believe, or what I already told, is that working with asylum seekers pushes us to think further than the borders of our basic training, of the framework that we got in our training. It pushes us to think out of the Western box. I didn't find a better word of that. So I'll go quickly through it. Once again, talking isn't easy. It's been said before. Individual therapy isn't always easy either, but blending into group therapies in the regular setting isn't either. What we feel personally is the biggest issue is that people lose their agency or control of their own life because of the procedure they're in. And so I think that therapy should focus on being empowering, on giving back agency and some proper responsibility to people, giving voice. Focus, not solution focused, but more recovery oriented, and focus on strengths. Some examples are also, I think, one of the most important things that our psychologists and our occupational therapists do is they don't focus on the vulnerabilities. They focus on the person and on the strengths, which gives you a whole different story. And it's important. Our occupational therapist uses these images more than only these, but in our first encounter to start a conversation. So she asked them to describe what they see, but also to choose, like, what do you like more? And that kind of opens up a whole different conversation, and you get into person's interests, person's strengths, what's going on. So it gives you a very different picture of what happens. Yeah. This is some images we use in psychoeducation sessions about the stress response to kind of bridge between body and mind. And this is a new therapy we will start both individually and in group. I don't know if anyone is familiar with it. It's the concept of the tree of life. It's a narrative methodology that uses the metaphor of the tree to create more complete stories of people's lives, empowering stories as well that are rooted in their own culture, but that also kind of try to project to the future. And then this quote of Maya Angelou that says it all, I think. Hola.
So thank you very much, Laura, especially for this very interesting case. I think it's which has illustrated a lot of points we are discussing on a theoretical basis. So for the last presentation before the coffee break, and I hope you still have energy, but because it will be a very interesting talk, I'm very happy that we could invite Brenda Anyango. And when we asked people, how do you want to be presented? She actually said, I'm a proud Kenyan based in Belgium, which I wanted also to mention, but you are also a clinical psychologist and a psychotherapist in training. And she also said, as a Black clinician, I have a special interest in diversity and cultural competent counseling and therapy. And I'm very happy that you will share your professional experiences with us. Thank you very much.
Jambo, guys. How is everybody feeling? Are we still awake? Okay, okay. I'll try to keep it short because I'm really happy that my colleagues already have spoken a lot about the things I'm really interesting about and really working with in the practice. So today I'm going to talk a little bit about practices of diversity and cultural competent therapy from the lens of a migrant, because I identify as a migrant. I am a migrant. And I'm also a clinical psychologist, a dance therapist, and like she already introduced me, I'm also on my second year a postgraduate in behavioral therapy, and I'm also part of the ELP. I don't know if you guys know, I don't know how to translate it in English. I normally don't do workshops or things like this in English, so bear with me. When I forget something, just go with the flow. For the agenda today, I really want to start with a question like, who is a migrant? And I will tell you why I'm asking this question. And then a couple of views and experiences on psychotherapy with migrants. So the stigmas and the barriers, which already some have been said or shared. Culturally sensitive care and implementing social justice into your practice. I'm so happy that my colleagues also realize that this is not just a situation of cultural competence, but it's also a justice situation. And then a couple of food for thought and references and recommendations. How do I want to play a video, I think, yeah. So before I do that, just for a second, if I would ask you who is a migrant, what will you think about? And be brutally honest with yourself. You don't have to tell me, but I'm going to show you this film and then we can go further from there, okay? Sorry, how can I make this? Technique. Sorry? I wanted to make it. The square. Yeah, but okay, wait. Yeah. And now going back. Okay. So who is a migrant? A migrant can be a person seeking medical treatment, a student abroad, an athlete playing for your favorite team, a seasonal worker, a person seeking safety and security. All around the world, people move for a reason. Some return home, some stay, some cannot return home. And the ones that stay build a life, a community in their new homes. But regardless of where they're from, where they are, migrants' rights are human rights. The migrants I counsel and I'm going to talk about today are mainly people from African descent that were refugees or students or people who are inhabitants of Belgium at this moment. And I'll come back when I'm going to talk about the biases, why I showed you and asked you the question, who's a migrant? So a couple of views and experiences on psychotherapy with migrants. I would like to start with stigmas and barriers. The first one is stigmas around their own community or they encounter in their own communities. There's a lot of misconceptions and taboos within some of these marginalized communities that make them feel ashamed, make them feel labeled, misunderstood, and judged. Therefore, they hide their conditions and often suffer in silence. The concerns that my clients always share with me is they're worried that people will consider them weak or crazy or even possessed. They're worried that they'll bring shame to their families. They're also worried that this mental health diagnosis will define them. They're worried to be a burden, an extra burden for their families because they're like, okay, we are still trying to make ends meet and find our ways in this westernized society. So we don't want to put extra burden to our families. And also they don't want people pitying them. Yeah, they're already strong in their own shoes. So they don't want people thinking like, because I'm sharing this, so I need your pity. Yeah. Also concerns related to privacy and confidentiality. Another one that often comes is the one worry that one's faith or belief in God may be questioned by the faith community or family, because there's a lot of people who, when they go to a psychologist in their communities, is seen like giving your back or putting your back for your religion, and you only have to think about your religion as the only way to help you cope with your mental health. Also, the judgment of one's racial identity as mental health concerns. A lot of people tell me, like, when they tell their peers or their parents they're going to a psychologist, that the thing they usually hear is like, that's a white people's problem. Yeah. Also the limited problem recognition, and this goes way back to slavery. The fact that they don't see problems as serious enough, even though it's very severe. And the ones that come at my practice wait way too long when it's almost too late to start looking for help. Yeah. So these are barriers like my clients really share with me that really prevent them from seeking help on time and getting the help that they need. Other stigmas are, I've seen like help-seeking behavior is affected by the distrust on medical care, and Lucas and Hannah and Laura already talked about that. There's a lot of hesitant in seeking help because they don't feel safe. And this also has to do with the colonial and slavery misconception, like you're too tough, you're strong enough, or they were so dehumanized and it's not seen as people. So there was no thinking about a Black person going to needing help. Yeah. So concerns are about the past evidence of significant misdiagnosis and or mistreatment medically. So for instance, if you go to a doctor and I've also encountered this one, they tell me, I cannot find your veins. If this happens like 3 or 4 times, I'll not go very easily back to my general practitioner because I'm just worried about the way it's going to go. Lack of culturally affirming, sensitive, and appropriate mental health services also very make people feel hesitant to look for help. And then the language barriers, financials, the cost is it's a high cost. Location of the services, due to the lack of culturally competent psychologists or psychotherapists, a lot of people have to travel miles to get to the right psychologists or therapists. And this can also be one of the reasons that they give up, or they're like, no, I'm just not going to start with going to therapy. Limited time, and also the waiting time for available clinician, number of sessions being too limited, and so on. For me, it's really necessary that we as mental health providers understand how mental health intersects with our identity and culture. Recognizing and integrating our differences and our needs is an important step towards building culturally sensitive and competent care for all of us. That's why it's very important to be more cautious about how you implement cultural competent services in your practices. So what does it mean to be a cultural competent, affirming, sensitive and appropriate therapist? I've listed a couple of things. It means that you have examined your own cultural biases, belief system, and how it shapes your worldview and the work as a therapist or a psychologist or a mental health provider. You have to be intentional about understanding the personal belief system and culture of your clients. Your clients have to feel like they're being received. And by that, I mean that like being respectfully curious and really asking questions from curiosity and not judgment. Takes into account your background, for instance, the gender, age, economic status, sexual orientation, race, identity, religion, and how it all impacts their mental health. Not making assumptions about who somebody is. Knows that mental health symptoms will present differently among different types of groups, and respect the differences between them, and communicate and interact from diverse backgrounds. Will make sure that goals and expectations are in line with the ones that your clients have. No, the clients in other way around. Okay. So people quite ask me, how do you implement that in your practice as a clinical psychologist? It's not like I have a book written, and it's more like the small things that I ask my clients that really make the difference. For instance, asking them how I can pronounce their names, asking them which kind of pronouns they prefer or use. Looking up or asking them what kind of typical holiday or festivity do you have in your culture? And by asking this question and actually remembering them, and when they're in this, when the festivities comes and I congratulate them, all of that, it just makes our bond, our clinical bond more in tune with each other. And they most often tell me they feel very understood and very seen and received by me. So recognition is a must. Learning to build trust and obtain a mandate is a must. Asking question, is it okay if we talk about this and that? Not just asking question, but asking them if it's okay for them to speak about things like that. Connecting rather than correcting is also a must. It's okay that your views differ, but instead of going like, yeah, here in our country we do this, you can ask, how do you do it in your country? This is how we do do it on that part. And for me, it's also important, especially hearing from the previous speakers about research and how important it is to not just be culturally competent, but also think about social justice when you're working with people with a migrant background. So for me, it's important to implementing social justice in your practice. And how do you do that? And is for the next slide. Like my colleagues also say, studies have shown that increased risk of depression, suicide, levels of anxiety, and stress-related illness are higher among ethnic and minority groups due to racism, discrimination, and negative life events. So we cannot claim to care about mental well-being if we continue to ignore the psychological consequences of systematic oppression. It is therefore very important to become aware of the consequences of racism and all forms of discrimination for mental health. So this is how I try to implement social justice, and it's an invitation for every mental health caregiver to just take this home and try to implement or ask yourself question or observe yourself in how do you try to implement social justice in your work. The first one is get ready to make mistakes. That I mean, don't minimize your privilege. A lot of my clients have been to other therapists or psychologists, and they come to me and they're like, yeah, when I was speaking about this, they were like, yeah, but white people also have a lot of problems. So they were like, yeah, okay, but I'm not talking about that at this moment. I just really want, so don't minimize like your privilege and the fact that you have more access to a lot of different things than people with a migrant backgrounds. So recognize the experiences of your clients that will never understand. It's okay. We are human beings. We are not able to understand everything of everybody, but recognize that and also just speak freely about it. Expect to enact in microaggressions. A lot of my clients say like the therapists or a care provider say like things like, you guys are strong in your community, or you probably also, if they're asking about their hobbies, you probably also can dance and sing well. Things like that. They're so small examples, but it makes other people feel very unsafe to share their experiences. So it's important to apologize and make repair. We are all human beings. We cannot know everything, but apologizing, making repair, and owning our mistakes fully makes space for our clients. So I also fuck up regularly with my hands. So it's okay, yeah? Name the oppression, say it. Instead of like going all the, trying to not talk about racism or discrimination. When a client of you tell you like, yeah, I had an encounter with, I was going clubbing and the bouncer did not let me in because of my skin color, that you just name it and say, that's not okay. That's ethnic profiling. So naming it gives it also, give my clients the idea that they are not wrong and that the system is the one is wrong. Okay. Promote equity. A lot of people are more busy with equality, and there's nothing wrong about equality, but I will say promote equity instead of equality, because equality is about sameness, and equity is about fairness. If you, for example, we think it's equality for, how do you say, for people to go to school. So everybody has to have access to go to school, but fairness is more about when you have access to go to school, there also are backgrounds that are needed to be in consideration, the language, the socioeconomic, and all of that. You cannot expect the same for everybody. So fairness is more social justice than sameness. And fairness means everybody getting what they need. Sorry, I forgot the D, in order to be successful. So I ask mental health providers to empathize fairness and realize how that may present itself in your practice. For instance, example I do, I'm not saying everybody should do that, but if I have a client that has financial problems and they cannot pay the session at that time, I work with a system that they can pay in how do you say, sorry? Installments, yeah, thank you. So it's not something I'm asking you guys, but you can also just think about what are the things that I, as a mental health provider, can do that feels okay for me. It's not because I give this example that is the only one you can use. Yeah, connect trauma with oppression is also very important. So trauma includes also the daily repeated microaggressions. And take an intersectional approach is also very important. Learn about the client's intersecting identity by asking yourself, what does it mean to hold their unique identities in this world? I'm sorry that I'm going very quick, but I just have 2 minutes. Food for thought. For you guys, especially the mental health caregivers, I want to invite you to think about what small step are you willing to take to contribute to justice and better care of racialized and marginalized groups. For me, is willingness, curiosity, and openness the key attitudes to change. Also remember, when you're working, especially in institutions and schools and all of that, being social justice and is important, like diversity, equity, and inclusion and justice takes place. So diversity asks how many more Black people do we have this year than last? Equity responds, what condition have we created that maintain groups as the perpetual majority here? Inclusion asks, is this environment safe for everyone to feel like they belong? And justice challenges, whose safety is being sacrificed and minimized to allow others to be comfortable maintaining dehumanizing views. Yeah. And a gentle reminder from Kathleen Buitenweg. I really love this quote because, again, we are all humans, we make mistakes, and we are just navigating in how we can provide and be more cultural competent and social justice with our clients. So it is important to realize that every human being thinks in images. Everyone has prejudice. That doesn't mean you're a bad person. The most important tip is acknowledge to yourself that you have those prejudice, and only then you can do something about it. And these are recommendations and references that I use. I would really recommend you guys to check all these doctors, all these mental health providers within the field of Black mental health. They really have workshops, trainings, resources that already are there. So it's the willingness. If you really want to help this group of people, there's a lot there. I know it's more from the US or the UK, but there's a lot that we can do to implement this in our healthcare system. And these are the ones in Belgium. And thank you. Asante sana.
Okay. Thank you very much, Brenda, for this really inspiring talk, also for giving practical advice on how to address certain issues. Really great and helpful. And also for addressing stigma and social justice, and for the self-reflection that I think your questions have triggered. So despite we are running late, it's not too bad, I think. I really would like and propose to keep the 10 minutes for questions and answers and for your contributions, and just go a little bit later in the coffee break. So there are some microphones in the room, and I would like to invite you, if you have specific questions to one of the speakers, please identify yourself and address the question to the speaker, or if you have any other just, contribution, input, or whatever, so just shoot. So there is one over there. Maureen. No, I think take it because otherwise I think it's maybe too complicated.
I have a practical question for Laura van der Vliet. My name is Maureen and I work as a social nurse in ITM, and I have experience with working together with the medical service of the centers to arrange psychological help. But I was wondering, how can we do the same for people who are not staying in a center?
Yeah, I think that's a difficulty we encounter as well when we try to refer people for further care after they've been with us. And it's a discussion I've had with colleagues of mine or fellows in my year when we were studying psychiatry. It's a big issue, and I think in the regular mental health care there's a lot of rejection towards working with asylum seekers, which has, I think, a lot of reasons. Some of them are practical, and not everyone knows how to work with interpreters, or they think it's a big burden because you have to book it and make phone calls and you have to organize it. I think for others, it's also a bit of like what we don't know, we don't want to do something like that. So it's really hard. I have the experience that in some centers we work with, they have a good connection to some people around the center. So I see now more often that people have an external psychologist, for example, to work with, but there's not a group list of people who are willing to work with our target audience, let's say, or it's hard. So I don't really have that many suggestions. To keep on trying and keep on inviting people to events like these, I think, to kind of point out the importance of trying to adapt the healthcare system to the needs of all people present in Belgium. That's what I would do.
Thank you. My name is Antea. I'm an anthropologist, so I don't know if I am the only black sheep here. I'm not really familiar with many concepts, but because of this, I have 2 observations and 1 question, so I hope we will have enough time. One is about the notion of cultural identity. I really don't know what that means, but sorry, that's maybe my anthropological bias, meaning that, so I was struck by Lucas' presentation, because it seems that culture and country mean the same thing, but that's absolutely not true. And so it's not enough for somebody to come from a different country to belong to a different culture. But yeah, that's just an observation. I think it's something we could discuss for hours. There was another thing that also struck me. We were talking a lot about interpreters. Maybe that's just the practice, but why not hiring, if possible, of course, people from other countries and cultures, because I think that could maybe lower this barrier or try to like invite people to be more to make this psychotherapy more accessible. As for asylum and exile, I think, yeah, there were these 2 presentations that were talking about that. Lately, I've been working with some Burundian exiles in Belgium, and I think that the main problem, at least for the persons with whom I had worked, was really leaving the country. So, of course, all that you have said, but I think that the very main problem was that these people had to leave everything behind and start a new life. And that's like a huge biographical rupture. And so that's like a bit of sort of like a background problem on top of which you have all the different aspects that you have rightly listed. Yes, finally, my question, it's a curiosity actually, and it's addressed to Brenda. Thanks for actually also shedding light on, say, the other side, so the patient's view. Given these, so this reticence or hesitancy for, to put it simply, Black people to go to white people, to white psychologists, put it very simply, which is also something that really resonates with what I had listened to. So what would be, why would Black people come to your practice, and what would be the motivations for them to come to you besides being Black? So is there like a sort of like trigger, or why do they come to you? Thank you.
Maybe to start asking that, because it's
Yeah. I think representation is important. It's not necessarily that Black people come to me because I'm Black, but I think the lack of a couple of attitudes that they have encountered from maybe other white psychologists that made them come to me. It's not like they specifically want to be with me, but the representation. And then for me, it's important that they just have a pool of, how do you say, so they have the ability to choose where they can go. And now I feel like because they're afraid, and all those barriers and stigmas that we just talked about makes them navigate quicker to me than to a white psychologist or a white mental health provider. But it's not a necessity, because in some cultures, even some people tend to go to other psychologists or mental health providers because of some reasons of like they're afraid it will come in the community and all of that. So it's not a necessity, but the representation and just having a pool to choose from can help them. But for now, because the pool is really small, then navigate more to somebody who looks like them, or where they have this idea that I will understand them better with my background. And they don't have to explain a lot of things in the way. Yeah?
Maybe about the cultural identity, yeah, because that was exactly what I wanted to, I think, illustrate, that people often put cultural identity equal to the origin, the country of origin or region or of origin. And what we try by creating a narrative about cultural identity, just to grasp all the different aspects that make someone who he is, and what is important about the person that we know, how he sees himself. And that's much more, of course, like you say, than only the country of origin. Yeah, I think it's really about, who are you? What do we have to know about you? What's important for you? It's about the person. Yeah.
And I maybe want to explain a little bit, because the interpreters that I work with, they are often people of, it's not Flemish interpreters that we work with. It's a whole range of people who are often, I think, themselves migrants, but yeah, as they are interpreters, they're sort of a neutral part of the conversation, so I don't ask them about their own background. And then you have what's called culturele bemiddeling, which is, it's not a strict interpreter. They're kind of, they use their knowledge about a certain culture to bring into the conversation and to explain certain shifts in ideas, but that's not always an easier way to work, because as we pointed out with this discussion about identity, we can maybe leave the word cultural out, but with the interpreters or the cultural intermediators, I think the word is in English, they don't forcibly have the same identity or values or ideas about the culture, so it's not, it doesn't necessarily make a conversation easier when you use them. There is, however, some evidence that like fellow lotgenoten contact, or people who have like the same experience of going through migration and an asylum procedure, that is very helpful to share within a therapy context. Yeah.
Okay, thank you very much. I think we should take the coffee break now, and then so we get some new energy, and then maybe we take 15 minutes to make up for some time. So we so 15 minutes is yeah. So we come back a 2:45, right?
Sorry, ineens de volgende al opzetten.
Ja.
Deze is deel 1. Ik hoop dat de Zoom aanblijft. Ja, hè. Dan moet ik eens checken.
Ja.
About the contacts in Belgium for
Yeah, but you can also receive the so this will be the same. If you want, you can receive the recording. But if you want to take a picture right now, it's also possible.
Nee, voilà, dus dat is deel 2. Maar nu weet ik wel niet voor de online mensen, omdat het scherm even gedeeld was en niet meer gedeeld, precies.
Maar is niemand online?
Nee?
Nee, er is geen hybrid. Het is wordt gewoon opgenomen. Huh? Dus ja. Ja. Ah, maar ja,
Dat is van alles geprobeerd, krijg je
dat is nu ook niet zo erg, hè?
Ja, ik
Mhm.
heb erover gekomen. Het is niet zo mooi, hè?
Ja.
Dus dat komt eraan.
Ja. Oké.
Yes, Maxime is here. Anne Hendricks, I don't know. I haven't seen her.
Yes, I've seen her.
Okay.
It's a small lady. She was a bit anxious.
Ah,
with the
okay.
Presentation to be printed.
Ah.
Study. So still study. But I think she's not.
She's not used to this.
She's a community
worker.
So
Yeah, but it's a nice mix of people, no? That I think is very interesting. Actually, I was thinking in the idea of the network, it would be nice that I mean the people that want to merge society that somehow have a mix of people.
Yeah.
En dan heights, floating meeting control.
But can we use it?
Als op escape drukt, dan kom je die terug.
Ah, the minute for yeah. But maybe specifically on the topic of mental health or not?
No,
would be
general,
specific.
because the first seminar was very general. The second was on COVID. The third was on data, like data and migration. Yeah, data and migration.
Maybe I think I will pull them now. Huh?
Yeah.
Hello, everyone. Welcome back. Shall we start for the second part of this very interesting seminar on mental health and migration? So I have the pleasure to chair the second part of this workshop and the pleasure to introduce you to the host of the workshop today, Christiana Nostlinger. Christiana is going to give an overview about intervention to improve mental health or mental well-being of migrants and ethnic minority groups in Europe. I think that's very interesting and important because we often have these global reviews, but now we're going to have something more specific on Europe. I will very briefly introduce Christiana. She's a trained clinical and health psychologist. Before 2005, before coming to work here for ITM, she's held various positions as a clinical psychologist, researcher, and lecturer, and consultant working in various European and international organizations in Austria, Switzerland, and the Netherlands. Since 2005, when she started to work for ITM, she's been leading several research projects on subjects related to gender and health, sexual and reproductive health, health promotion for key populations such as migrants and young people. Well, thanks a lot.
Okay, thank you. So this is really meant as a short introduction to the second part of the afternoon, where we look at interventions. And I'm presenting this, but really presenting also on behalf of Hanne Apers, who really made the bulk part of this work, really. So it's a literature review that was commissioned. So we were asked to conduct this for global mental health. And it's also available online. So if you're interested in the more detailed results, at the end of the slides, there is the link. And because we tried to do this in 10 minutes to make also space for other presenters. So I will really just present the main, the main messages, really. So we have heard a lot in the first part about how intersectional and structural vulnerabilities limit access of vulnerable migrant groups to mental health care. In European countries, despite even if there are maybe, let's say, different results, but despite a high prevalence of mental disorders. And in fact, I would like to mention that really migration and healthcare policies, or the interface of those two, has become very exclusionary during the last decades. And most European Union, European Economic Area countries base access to, between brackets, mental health care, but of course it's a general problem of healthcare on immigration status. And this reiterates and increases mental health inequities. But despite those policies, migration will increase in the future. So no doubt about it, due to ongoing humanitarian, geopolitical conflict and in conflict-related areas, and also climate disasters. So, but unfortunately, the migration topic has become very politicized. So evidence is really urgently needed for policymakers, but also for mental health care providers and for affected communities on what are really effective support structures and effective mental health interventions. So this article, as I said, this article is available. It's an open source article. And I would also like to mention that we focus on migrants and ethnic minorities as a category here, but in the same issue of the journal, there's also an article on asylum seekers and refugees. So the journal kind of commissioned two different articles. And you will have that reference also on the last slide. So what did we do? We did a scoping review. A scoping review is not, it's a systematic search method, but it's not a systematic review in the sense we did not assess the quality of the articles on those interventions, but there is a kind of a stepwise approach to do this in kind of a best practice. So we followed those guidelines, which you have them listed here. We used also the PICO approach, which is about phenomena of interest, the context, and so to kind of develop the review question for this narrative review. So our review question: what is known about interventions applied in the European Union, European Economic Area, and the UK, because we also wanted to include that literature, of course, about interventions that improve migrants and ethnic minorities' mental health or mental well-being. And you see the definitions here, but I'm not going to read them. But in terms of defining the inclusion and exclusion criteria, I just want to point out that we excluded purely medical or pharmacological interventions. So we found, which you can see here on the Prisma chart, we found about 600 articles which were screened. We excluded several articles in line with the steps of the Prisma guidelines for scoping reviews, and we ended up with 27 articles. So on this slide, you can see that in terms of the gaps, there are a few countries in Europe that conduct, or where researchers conduct the bulk part of the research. So countries like the UK, the Netherlands, or Sweden, and other European countries as well, which then have had only maybe 1 or 2 studies among those 27. We have a fairly good mixture of quantitative, qualitative, and mixed method articles. The last diagram shows you the type of interventions according to a certain category. So there are quite some interventions that focus on social change, but there are also lifestyle interventions, there are self-help interventions, there are psychoeducation and health education interventions. So in order to, because I have limited time, I just give you the main messages of this article, and I invite you to read the article then. So what works? What do we know among these 27 articles? What are strategies to increase acceptance of specific interventions, the actual uptake, and also positive outcomes? So, and by asking that question, you already see that it's very difficult to compare these 27 studies because they measure very different things. So it's hard to draw like one red line or one big conclusion. So, but we identified 3 major principles that seem to contribute to effective interventions. The first one is that interventions are culturally adapted to the needs of the target group. And the target groups, of course, or the populations that these interventions address, they are also in these articles very heterogeneous. So you need always different contextualization of the methods originally used. So there were like 11 studies that used certain cultural adaptation strategies, either to the content of the intervention or to the methods, the strategies in terms of how the interventions were delivered. And maybe very prominently, for instance, an example could be interventions based on cognitive behavioral therapy. How do you adapt such interventions to the needs of a certain migration population? One of those strategies, but which we highlight as a very specific element and ingredient because it's so important, are participatory approaches. They can also be used to adapt interventions, but they are also, let's say, a method to develop interventions in their own right. So co-design, co-production, and community-driven interventions are also very successful strategies, but they are often not evaluated to the same degree because very often these articles were also just more describing the process of intervention development. And then finally, that's something which may be true for any intervention, and we know this also from the HIV field, from prevention research. So if interventions have an explicit underlying theoretical basis, and if they make this explicit, they are also more successful. And I've put here some of those examples. So these 3 strategies or main ingredients of interventions are also at the same time the facilitators to make an intervention more successful. And you see here also on the slide here, there are also barriers, and these barriers to intervention uptake, for instance, they very often relate to the social determinants, to mental health related stigma, and to interventions not being sufficiently adapted to the population they want to address. So, and then the second question would be how do interventions actually work? So what is it that makes them effective? So what are the underlying mechanisms? And there we have to differentiate between the level, let's say the level of the socio-ecological health model, which level do those interventions address? And a bulk part of the interventions, they address the individual level. So then we talk about, like, for instance, increasing the knowledge, increasing individual skills, which of course can also increase coping mechanisms. And through better coping mechanisms, outcomes as, you know, better self-esteem, better self-efficacy, and then eventually you would see changes in improved mood, depression, anxiety, these kind of things. Another group of interventions addresses the social and community networks and engagement at the community level. So this is mainly the mechanism there would be through creating social networks in the community. And of course, there you also have the participation, you need the participation of communities affected. So here, what we saw mainly as mechanism is reduction of stigma and increase of social support. And through that, again, individual agency has been increased. And then on a higher level, I would say also very important, adjusting the mental health system to migrants' needs, which here we see interventions that, for instance, address the provider-patient or client relationship, the communication, so also things that were mentioned before the break, like this cultural competence is, for instance, part of that. But we go nowhere if we don't include migrants in the mental health care governance, because we know that the participation really improves ownership and also subsequently uptake of interventions. So I come to the discussion and the conclusion. Of course, this was only a scoping review, as I said in the beginning, so we couldn't do really a quality assessment. And the studies were very difficult to compare with each other because they measure so different things, different outcomes, they use different methodologies. But just to highlight that cultural adaptation and participatory approaches are really necessary if you want to have effective interventions to improve mental health in these populations. And certainly a larger part of the studies address determinants at the individual level, but I would say the evidence also on studies addressing like more layers of social determinants are increasing, though they may not be evaluated with the same scientific rigorous approaches as individual studies, because it's just very complicated to conduct randomized controlled trials if you have those, you know, all layers of influencing factors. So what is needed are, because so many factors on different levels have an impact, what we need are holistic and intersectoral approaches, including, of course, the policymaking area, because it's actually there where those harmful structural drivers originate. And at the same time, this would also require a better representation of ethnic diversity within the healthcare system, which maybe addresses also, or is in line with the question that was also asked before. Thank you very much.
Thanks, Christiana, for being so on time and for bringing us really to the core of the session on intervention to improve mental health among diverse population and see what does it work? If something works, given the context of social injustice in which migrants and especially asylum seekers and refugees experience and live today. So now I welcome to the stage Maxime Renaud. Maxime is a clinical psychologist at Médecins Sans Frontières. He has been working throughout the world, if I'm correct, and has extensive experience in the field of psychotrauma, crisis, and intercultural intervention. He's going to talk about psychological aid at the Humanitarian Hub in Brussels.
Hello, thank you everyone for having me and the hosts. I'll try to be as concise as possible for the well-being and mental health of our hosts. But the truth is there's a lot to say. So I'll try to skim the surface, let's say, and we'll go from there together. So humanitarian aid in Brussels, it might shock a few people. It certainly shocked me when I started working in the field. So if you'd indulge me for a second to just do a little bit of advocacy, I'd like to remind everyone that is here and the one that are watching that as of today, migrants and asylum seekers that arrive in Belgium experience at least weeks, if not more commonly months, of street-like living conditions while having undergone systemic physical, sexual, psychological abuse and torture. These abuse happened, of course, in their country of origin, but almost always also on the migratory path and in European countries. So it's in that setting that we do humanitarian aid and why there's humanitarian aid in Belgium and in Brussels. I work, amongst other things, in the humanitarian hub. I don't know if a lot of people know about it. Certainly in the field, it's well known. It's been there for a few years. And MSF, Doctors Without Borders, is certainly not the only one working there. It's a regroupment of many NGOs, some international, some more locals, that gathered together in one place to help migrants, asylum seekers, undocumented people. It's the Red Cross, it's Brussels Refugees, also known as Plateforme Citoyenne, Doctors of the World, SOS Jeunes, who works with the youth, and of course, MSF. Each of these organizations have specific roles in the hub, and we try as much as possible to cooperate in a single place to be able to provide better care. So quite rapidly, what is the hub? It's one and foremost, it's a place to rest, to offer safety, a warm environment, offer coffee, electricity, Wi-Fi to reconnect with the people that we care about, and activities, ping pong tables, basketball. So it's a living space that is open during the week and during the weekend. It's also services, primary care services, meals 2 times a day, toilet, shower, hygiene products, clothes distribution, shelter referrals, Restoring Family Links, that is the Red Cross that is making sure that people can call internationally and find members of their family or community. And orientation of vulnerable population, we mean women and youth, menas, sometimes called. And it's specialized service, which is in an adjacent building, but it is all in one compound, let's say, where professionals work, so doctors, midwives, psychologists, jurists, and social workers. And so through this living space and specialized service space, which we sometimes call ticket space because they need a few tickets to access the services, we try to offer a space where these population can access easily a broad spectrum of services. So what is MSF doing in the hub? and around the hub. It's specialized in mental health. So I was saying each organization has a reason to be in the humanitarian hub. MSF is concentrating its services around mental health. So we've got a first line at the hub, which is basically an unconditional reception to people that ask to see a psychologist. It's psychological first aid. So basically just making sure that people that are highly emotional can have a space to calm down, to maybe gather their senses a little bit if they're in crisis, and we go from there. It's also a place to do evaluation for needs and demands. What do they need? What do they require? How can we provide maybe some sort of psychological follow-up? It's evaluation, so diagnosis, eventually, mental health certificate, and it's eventually a referral because, of course, we cannot provide everything because there's too much demands. As a general maybe number, there is around 1,000 meals that is being given to the hub every day. Of course, some people eat twice a day or more, but that gives you a broad spectrum of how many people and the flux of people that come through the hub. Now, I would like to bring you to the topic of this presentation, which is how can we adapt psychotherapy or psychological follow-up to this kind of population? Because after the first line, we offer a second line. The second line is a multidisciplinary approach to mental health. So I certainly do not work alone, and I'm really glad. I work with other psychologists. I work with doctors and social workers. We work also with psychiatric nurse that help us provide that second line services. So that second line is basically psychological follow-up and therapy to whoever needs it in that population. Now, a quick word of it, because I could not mention it. We're here at the Institute. We're working within the walls of the university as well. Everything that we try to do at Doctors Without Borders, and I think from what I've heard so far, is the same for you guys, is evidence-based. We try to apply what we do, what we learn through evidence-based practices, and more particularly in what I do in evidence-based therapies. So a culturally sensitive approach to psychotherapy, that is what I'm trying to explain to you right now. It doesn't start in the consultation room. And sometimes people say, yeah, it's obvious, but I think it's important that we take the time to make hospitality and the first contact with the population a core element of what is psychotherapy and what is psychological follow-up to this population. So hospitality become a non-neutral starting point to the services that we offer. And it doesn't have to be psychotherapy. It's when a social worker welcomes a new beneficiary, when just someone volunteering, doing volunteering work meets them, is the same thing. Is the first contact that matters the most. And so it's about offering them a safe place where they can rebuild trust, because as a reminder, most of those people have had severe experience of betrayal, mistrust, abuse by individuals, but also by organizations, and in some cases by NGOs as well, abroad and here. And so it's about recreating a first step into that trust. It's also about welcoming them in a way that correspond to their code, their social norms and social codes, to make them feel welcome. It's also obviously about bringing them back a little bit of dignity. They're not nobody, they're a human, they're an individual that deserves to be seen, heard, and recognized. So I was happy to hear a lot about interpretation earlier today. At Doctors Without Borders, we call it, as someone said, intercultural mediation. So I will refer to ICMs as a short way to say it. I could not put more emphasis on how important it is. It is not just best practices. I think it is essential for practitioners and clinicians to work in that field with intercultural mediators. So they're not only interpreters, they're professionals that have learned the way to interpret, but have also learned to bridge a gap between different cultural frames. It's the possibility to offer to the patients and beneficiaries a way to express themselves in their own words, in their own native language, which is so important when we try to convey our distress and our complaint. And there's always, of course, there's challenges, as some speakers were saying before, but I think it's important to remind ourselves that those challenges are part of the work. And so, of course, sometimes a patient might ask for someone from a different cultural background, maybe because there's a conflict inside their countries between different ethnicity, and it's okay. That's why we have a broad spectrum of ICMs from different places, different languages that can help adjust those things. And as just a quick point, we do use ICMs even when the patients speak the same language, because it's not just about bridging the language, it's also bridging the culture. I'll try to go a little bit faster because I see times is running out. All right, so obviously, previous speakers have talked about about symptoms. We see a lot of PTSDs, we see a lot of depression. What I might say maybe very quickly is that it's astonishing, not just the amount of PTSD we see, but the amount of complex PTSDs that we see. And that is, as I'm sorry, I forgot your name, but our previous psychiatrist colleagues mentioned, those type of patients are really, really difficult to treat, and also they suffer a lot. So it brings us in a situation where our clinical work is really not easy to do, and those people need as much help as they can. So how can we, in our practice, diagnose? I would say it's important to have a culture-specific analysis of the reactions and symptoms. I'll give you briefly a little example just to bring you, let's say, in that field of thinking. Kufungisia is something that I learned when I started working at MSF, is a word from Zimbabwe that means overthinking, but it's a word to describe depression, right? So what's funny is that that word in this specific country or culture is a criteria for depression, but for us it's a criteria for anxious disorder. It's a quick, simple example that words and the way we express and talk about our distress and our symptoms matters a lot by the way we diagnose. And therefore, it's important to adjust our lenses and our analysis of things. Same things with animist beliefs and group apprehensions. Group apprehensions is when a group of people can react together to an event. We've seen that after the genocide in Rwanda. So those kind of things and events and are culturally coded and are important to take into consideration when we work with patients. So, in that matter, how do we practically do that? We use specific scales that have been adapted to and have been evaluated to those specific population. Quickly, but you can read them online. There's a RHA 15, SDQ 20, HDQ 20, ITQ. I really like the IESR and the ES2, but those two can be sometimes really complicated for the beneficiaries, and so it's important to adjust the tools that we use. And in therapy, we explore a lot of things, but we explore specific resources because this is part of how we can stabilize them. And so faith in community is something that myself is not is less important than some of the patients that I see. And so it's important for me to be sensitized to that type of approach. And so we're talking about non-harmful traditional caregivers and counselors, religious figures, traditional healers, but also ceremonies, ritual, and faith in general, like praying, which are things that we reinforce when the patients come to us and when they say, how can I maybe resolve that kind of problem? A close relative die, how can I be at peace? How can I stop suffering? It's those kind of coping mechanisms that we will reinforce. And so it means that we have to adjust our framework. It's a matter of access to care. The hub, just like when we do therapy, when we offer psychological follow-up to the beneficiary, we need to aim at low threshold access. That means that we need to accept walk-in consultations without appointments, that we need to allow the presence of a relative, a friend, or a community member. That means that we need to adapt our tools, the use of WhatsApp, Signals, applications to communicate easily with the beneficiaries. And it means also to adapt our rhythm. I'm used to see a patient every week, every 2 weeks. That's not the case in this kind of clinic. And so to keep almost perfectly in time, I'd like to end with how can we adapt the psychotherapy itself. And so I think it's about, as some speakers said previously, to change and adapt the tools, the approach that we learned at university, that we learn in seminars, that we learn in developing programs that you follow and trainings that we follow. And so one of the things that I would say is important to do first is to take into consideration when we do work with those people to assess the secondary benefits, specifically with asylum seekers, as sometimes we notice that there's not a lot of change, and you realize that those people are scared that if they're not depressive anymore, if they don't suffer from PTSD symptoms, when they ask, when they have their interview at the CGRA, they won't be taken seriously. So that's the first thing that we need to adapt. The second thing is all about consent, physical proximity and touch, and offering them a sense of control. That means that when I work with those patients, I need to take my time to discuss all those things. I practice EMDR with those patients. In EMDR, we sometimes touch patients. We touch the knees to do bilateral stimulations. I need to take into consideration that touching is a really touchy subject. Excuse me, the bad analogy, but it's something that might be difficult. The tools that we use in EMDR, we also use sometimes a little vibrating device or light device, can trigger some things that they lived in their own country, if they've been electrocuted, if they've been tortured. So all those things need to be adapted. And specifically the way we use those protocols. So for example, typically I will start by working on the source materials. Source materials meaning the initial traumas that they lived through. I might choose, and I would say, and we would say that is recommended, to start working rather with resources, triggers, and working on future plans and behaviors to those triggers. So by starting with those things, you assure that the patient that we meet can stabilize and eventually work on what caused the traumas and the triggers of their different mental disorders. I skimmed really fast. I think there's a lot to say about it, but if there's one thing I would like you to remember, I think, about this presentation, it's about access to care and lowering the threshold. And by doing that, you, as my previous colleague said, you allow yourself to change the way you operate, question the way you operate in the consultation, but also around the consultation when you're in contact with those beneficiaries. That's it. Thank you very much.
Thanks a lot, Maxime. You've been very punctual and very interesting to hear Again, there's a specific experience from the humanitarian hub in Brussels. But up to now, we've heard, let's say, institutional practice, a practice from international organization. But now we want to hear how migrant groups themselves self-organize to provide support for their own community. And we start with Erikair and Hendricks is our next speaker. So Anne works as a coach within the Federal Community Health Workers Project. She collaborated with community health worker Nikat Sereke and Open Network VZW, and they established Erikair, a group therapy initiative centered on migration, trauma, and resilience, tailored for Tigrinya-speaking refugees. And we'll delve deeper into the details of Erikair during her presentation. So welcome, Anne. Unfortunately, Nikat is ill. So I brought her with me to the picture. So here. Okay. Where do I have to press? On this one? Yeah. Okay. Yeah. Voila. Okay. Thank you. Community health workers. First, I will explain a little bit the general framework of where Erikair has been developed. Community health workers, the aim is to bridge gaps in the health system. This is a beautiful picture of almost all of the community health workers in Belgium. As you can see, they have different origins. They come from different countries, which is quite important for this project because they have a lot of wisdom and knowledge, and they are experts in vulnerabilities and refugees. Our mission of this project is to act as a liaison between health and welfare services and communities in vulnerable neighborhoods. We facilitate access to services and improve service quality. To increase the knowledge about health and self-reliance, to sensitize health and welfare professionals on the importance of appropriate communication, and I have added also attitude, a proper attitude towards vulnerable people, and inform them about the effects of social determinants for health on the lives of patients in their care. What is the profile of a community health worker? They come from or have close affinity with the target group or neighborhoods. They have knowledge of different languages and a connection with certain neighborhoods or communities. Their knowledge and understanding of problems that people in vulnerable situations experience with healthcare, they have experienced it themselves. So they know how difficult it is, which is their main motivation of being a community health worker. And they have a lot of very important soft skills. As you can see, this is a federal project. We started in spring 2021, and so far it will end in December 2025. But we hope that we can stay and continue. Me, myself, I am the supervisor from Ghent, and also Nikat is a colleague from Ghent. The target group in this project is people who are at the crossroads of different vulnerabilities.
that are intertwined and that may reinforce each other. And also hereby, I think the intersectionality approach from Kimberly Crenshaw is very helpful and important. And they experience all kinds of obstacles in their access to primary health care. And healthcare is very hard to reach for them. And these people who live in poverty, exclusion, homelessness, as a refugee in remote areas in the city, are without legal residence. These are the main strategy in bridging the gap with the healthcare system is outreaching. So we don't stay in our office and waiting for the people to come to us, we go to them, which means that we are present in public spaces, but also in places where these vulnerable people are present. And most of the times it's like kind of safe spaces. Social housing blocks, social restaurant, food banks. We work closely with local organizations in health and non-health. And we go out with embedded organizations, street workers, mental health outreachers. And of course, publicity is important because we are not very well known. Oops. Oof. Okay. Cooperation is the key. It's very important. What we do, we cannot do it ourselves. We are bridging the gap. So we build bridges between communities, people in vulnerable situations, and professionals. So cooperation with policymakers to make them aware that in their policy, socially just framework is important and that improving living conditions is important. Also care providers and care institutions, but also midfield organizations, the mutualities, and also the community health workers who are the link between all of them. Now, ERICare. ERICare, what is ERICare? Now, ERICare is group therapy. Let me see if I... Okay, is group therapy focused on migration, trauma, and resilience. The country of origin where these people come from, they are from Eritrea, Sudan, Ethiopia, but the main factor is that they speak Tigrinya. So the languages used during these sessions are Tigrinya and Dutch. And where do they come from? From Erigent, which is a self-support organization for the Eritrean community. It's organized and run by themselves, but also via doctors or healthcare professionals. They send participants to the ERICare sessions. Oh, weer al het verkeerde, sorry. Yeah, okay. What caused this project? Mainly frustration and angriness with Nikat and myself, because there were very long waiting lists in the psychiatry, but also with psychologists and therapists. We were very frustrated in finding proper help. We wanted to avoid, as they call it themselves, writing psychologists, which is a Western approach. They have experience with psychologists who sit, listen, and write down, and which is very strange. They experience it very strange. They don't feel helped. Yeah, I see you laughing, but it is. We had previous successful experience with a therapist from African origin. And the way she worked was more active, like she used concepts that the participants know, for example, I am your elderly sister. You can, this is apparently a well-known concept in Africa, and excuse me if I say it now very widely, but this is a well-known concept for them. And there are only few therapists and psychologists with sufficient experience and knowledge in cultural sensitive care in combination with trauma. And these psychologists must also be member of the convention, which means that they agree with official price setting, which means that the sessions are affordable. Maybe very shortly, there was a specific cases who made us frustrated and angry. It's about Freweni, a very vulnerable woman. She flee from Eritrea with one child. The child, when during her flight, she experienced rape, abuse, slavery. She was her flight took 2 years, I think. And when on arrival, her child had cancer, leukemia. So she lived a few years in a hospital. After 4 years, her husband came with family reunification, but he came with a lot of expectations because about housing, affordability, labor, and so on. And there was some domestic violence. And all of this led to psychosis and suicide. The husband and her family-in-law considered her as stubborn, but also as possessed, that she had the evil eye. And she had been sent to Ethiopia to undergo a kind of a ritual. After the suicide, she wanted to kill herself with a knife, and the police was phoned. They brought her to I forgot the word, crisis psychiatry, and she was sent immediately back home because they didn't speak the same language. So this is like, okay, solve your own problems. Also with the husband and the children who experienced this terrible situation. It was terrible. Also the psychiatric, she had a session every 2 months and said that was sufficient. She said she was confident that Freweni would take her medication. Of course, we knew she threw it away in the dustbin. And in fact, it was Nikat who, at this very crisis situation of suicide, who helped. It was in the weekend, and she helped the family and the children and the father, connecting other people from the Eritrean community to support this family. Well, I can keep going on, like what we experienced with other kind of psychologists who, well, I will talk about it later. I have to continue. What is a concept? It's 24 sessions, 8 for male, 8 for female, and 8 for youngsters. And it took place in a safe space. As you can see the photo, the picture, it is in a place with weekly meetings from Irigant, the self-supporting organization, which was very important for them. What was the approach? The topics were very recognizable by the participants. We did not communicate, please come do therapy to deal with your traumas. Then nobody would participate. But subjects like, why do I sleep badly? Why is it so difficult for me to learn Dutch? What is my identity? Why do I have physical pain without medical cause? So, and this is group sessions, of course, followed by individual therapy if necessary. And who does it? I am very happy to know that Koen van Praat is sitting there. With all of frustration and angriness, we ended up with him. And we had immediately a very good connection. We felt very understood. He recognized all the barriers and obstacles that we faced. So, and Nikat Sereke, she is also Eritrean. She is a trained nurse. She also has worked in the hub in Brussels North with Brussels Doctors Without Borders. So she has a lot of wisdom and experience. So she has the same origin as the participants. She knows the suffering of the community. She knows the community very well. She can translate what Koen is saying, but also what the participants saying, and that's more than translation, because she knows them in person, and sometimes she can really poke Koen during the session and say, Koen, didn't we plan to talk about this or that? Because she knows that person has this fear or obstacle. So this is really building bridges between healthcare and the community, and also providing culturally adapted health information. But the psychologist is, of course, also very important, because we are no therapists or psychologists, and he's very experienced in culturally sensitive care and trauma. He has lived and worked in refugee camps in Eastern Europe, and if I don't misunderstand, if I'm not wrong, it is in Kosovo. Okay. But this is, I mentioned this because this helped also the participants, like, okay, maybe he's white and he's male, but he knows what he's talking about. He has experience, he has lived and worked in a refugee camp. He knows how awful it can be. He is very enthusiastic. And his strength is that he can provide theory and practice without preparation, and he can really provide a context to the problems the participants tell immediately at the spot. And they're a really very powerful couple, Nikat and Koen. They are very powerful. Eriker, okay, this is my last picture. This is a picture of the group session with the women. I had more pictures, but because of my lack of technical things, I had to throw them out. But later on, you can ask more questions. These are my contact details. Thank you very much.
Thanks a lot, Anne, for bringing such a important lived experience from the Edicare project. And now I welcome our last presenters, Anna Karpenko and Anna Maria Sukar. So Anna Karpenko is an Ukrainian displaced person herself, an accomplished program director at Empatia. With a solid educational foundation in legal studies and organizational psychology, Anna brings a unique blend of expertise to her role. Her responsibility as program director are to oversee the successful planning and execution of the program. She's going to talk about it. Anna Maria Sukar is also an Ukrainian displaced person, professional, holds a master's degree in sociology and social research from Utrecht University. Presently working at the Opera Foundation as reporting officer for the Empathia project. Her key role encompasses program monitoring and evaluation, along with the development and implementation of a research strategy for Empathia. Sorry, Anna Maria, maybe you're not displaced. You're just a high-level professional from Ukraine that has been living in the Netherlands for a while. So I welcome you here to the floor. And yeah, so I just want to say that Empathia is acting and working in the Netherlands at the moment, and is part of this larger Opera Foundation that has been a kind of response of highly skilled international, but also Ukrainians that trying to respond to the crisis situation in Ukraine. So welcome.
Thank you. Good afternoon, everyone. It's my pleasure to be today here and to contribute to this event. And I also very inspired actually what I heard before. And also I'm very happy that it's also similar to our thoughts and actually our findings from our program. I will skip a little bit about our foundation. And want to start from this slide, that Ukrainian displaced people in Netherlands at this moment we have registered more than 1,000 persons. So you can see how the number grows. And the difference between actually displaced people and refugees or asylum seekers is that their status is temporary. So they are covered by European Union Temporary Protection Directive, and and also the difference that Ukrainians have direct access to labor, to housing, so they don't need to go through asylum seeking procedure, but at the same time, due to their temporary status, it's also impact on their mental health and how they feel themselves in this situation. So the problem statement, what we see last year in the foundation, that first, according to the study, refugees are at extremely high risk of developing PTSD and other serious severe mental health problems. Also, even before the war, a lot of people in Ukraine suffer from depression. So that also compare to the Western Union. And of course, we see language barriers and cultural difference and shortage of mental health professionals in the Netherlands. And all this actually impact on the accessibility of mental health care for Ukrainians in Netherlands. That's why so when we've thought about how we can address all these problems, we choose holistic approach, and that's actually how our program was developed. Empathia program is that's mental health support for displaced people from Ukraine in Netherlands. Made by Opera Foundation, of course, with partnership with Refugee Council. And supported by Ministry of Justice of Netherlands. So we are supported by government. That's helped us a lot. And we have 3 target groups in our program. So first is, of course, Ukrainian displaced people themselves. So that's people who in need for mental health support or help. Second group, it's municipalities and organizations who need actually consultation how to organize culture sensitive psychosocial support on the locations where Ukrainians live in, or in general in their regions. And the third group, it's Ukrainian mental health professionals who most of them are also displaced or just lived in the Netherlands, and they are looking for a job in their specialty. So we have like a shortage of psychologists in of psychotherapists in Netherlands. At the same time, we have like a database of Ukrainian specialists who can work in their own language with Ukrainians. To address these target groups, we have different activities in our program. So first for Ukrainians, that's an informational hotline. At this moment, we have more than 2,000 already, sorry. Almost 2,000 requests from Ukrainians. We launched our program in May 2022. So that's actually for this short period, we have a lot of requests, most of them about the need for help. So Ukrainians seeking for help. Also, we have for Ukrainians, we have support groups, workshops, and training. So that's more for psychoeducation. So to also to reduce the stigma, to inform people what mental health is, how they can get help, why it's important, also to normalize actually that it's normal, because for Ukrainian it's not very easy to say that they need help and to ask it, also because of different barriers. Also for organizations and for Ukrainian psychologists, we have matching centers. So we have database of 150 Ukrainian psychologists who's interviewed, their diplomas is verified, and we know all their skills, knowledge of languages, and we are matching them with Dutch mental health organizations. So at this moment, as a result, we have around 20 placed Ukrainian psychologists in different mental health organizations and municipalities who can provide therapy or consultation in their own language to Ukrainian people. Also, we are working with Ukrainian mental health professionals to help them develop their professional skills, so they can be their rate of their placement will be higher. So we provided CPT course and PTSD course in the last few months. And we conduct guidelines on employment. So just also to ask their questions, how they could be employed, what their rights, what they can expect on work, about supervision and other different questions. So they are also more confidence actually in what they can do and how they could provide help to other people. And also for municipalities, we are providing cultural sensitivity trainings also to inform municipalities and locations about difference in culture of Ukrainians. So what is important to them? What is what is stigma? What is normal? What is not? So that's one. And also in general, like we are providing like consulting services to municipalities and location in region. Also how to make the psychosocial support provided in their regions more culturally sensitive. So our psychologists who is working in our organizations, they're helping them to organize actually psychosocial support on locations. And as a part of our activities was also needs assessment. That's important because the general idea of our program, not just to provide any type of activities, which could be addressed to barriers, but also to understand the needs of the people and to know what they need and how we can help them. And about needs assessment, I will give a floor to my colleague and she will tell you more.
Thank you. Good afternoon, everyone. As been said, my name is Anna Maria and I work at the Bora Foundation as a researcher and reporting officer. And I'm happy to present the results of our mental health needs assessment that has been developed as a part of our program development and was aimed to get a better understanding of Ukrainian displaced people needs, their help-seeking behavior, and also to reveal the obstacles that Ukrainian displaced people may encounter. So the data collection process took a three-phased plan. We started with exploratory stage, when we were establishing contacts with mental health care providers and also Ukrainian displaced people. And this helped us to conceptualize our data collection and recruit the interview participants. The data collection itself took place during June-August 2023, and we used a mixed method design, meaning that we were collecting data both qualitatively and quantitatively. And as for the qualitative phase, in total, 10 interviews with Ukrainian displaced people were conducted. And as for the quantitative phase, we launched an online survey that yielded 504 respondents that finished the online survey. They were self-selected through online recruitment, and some of the variations have been excluded. So the final sample that we had was 494 people. So we were discovering the mental health of Ukrainian displaced people based on a PHQ-4 scale, which measures the level of psychological distress based on 4 questions. And the total score has been calculated as the sum of the scores for all 4 questions. And so this score can be categorized. And according to our results, 19% of displaced people in our sample were demonstrating a normal level of psychological distress, while 36% were showing moderate level of distress and 45% of people were showing moderate and severe level of psychological distress. Besides, we calculated the score on 2 subscales for anxiety and depression. And as we see, the results suggest that 57% of Ukrainian displaced people might be suffering from anxiety and 49% from depression. And at the same time, it suggests that Ukrainian displaced people might be, 61% of Ukrainian displaced people might be having anxiety or depression, while 32% could have both anxiety and depression. This slide is about mental health seeking behavior, and we explored it by asking people a question whether they felt the need for professional mental health help during the last 6 months. And as a result, we can see that 68% of people said that they felt such a need, and out of them, 31% actually were looking for professional mental health help. 46% are planning to look for professional mental health help, but 20% are not planning to look for it. And we also see that out of 31% who were trying to get the access, 49% didn't manage, which points to the obstacles and brings me to our last stage of the research, when we were revealing actual and potential barriers in accessing professional mental health help. And it can be categorized into 3 categories, and I'm going to start with system obstacles. So according to our research, Ukrainian displaced people are struggling to get the referral from preventive services and GPs to specific curative services. In fact, according to our research, only 6% of those who were trying to access the system through the GP succeeded. And this tendency has been also confirmed by our in-depth interviews. So you can see the quotation saying that he, meaning GP, had prescribed sedative herbal preparations that did not help, and he didn't want to give me a referral for therapy, even when I spoke about suicidal thoughts. Second category of obstacles are cultural obstacles, and they include fear, being shy, and stigma, and of course, lack of knowledge how to identify the mental health illnesses. And even though we acknowledge that this issue is present, I would like to stress that a lot of times it's been exaggerated. So even from the previous slide, we can see that only 20% of those who felt the need are not planning to look for it. And this could be, of course, due to the stigma, but also to other obstacles, which brings us to our third category of obstacles that are structural obstacles. And as you can see, we found that lack of financial resources is also a very important obstacle to receive care. And why one might wonder, so how come the lack of financial obstacles can be an issue, since Ukrainian displaced people are entitled to insurance that will cover their expenses in the Netherlands. However, as our results presented, most of Ukrainians who are managing to get help do this by accessing it through the private psychologist in Ukraine, which might be pricey. And the reason for this is also, we believe, language proficiency. So a lot of people don't speak either English or Dutch, or their level is not that confident. And also there is definitely lack of understanding of how to access the services. And on the right, you can see the quotation again, that if you sometimes cannot explain in your native language, how will you explain something to a person from another culture in another language? So summing it all up, this mental health needs assessment sheds a light on many aspects of mental health of Ukrainian displaced people in the Netherlands, and served us as a platform for development for other activities. And this brings me to the end of this presentation. Thank you all, and we encourage you to visit our website and contact us for more information. I'm gonna leave this if you want to to scan it.
Thanks a lot, Anna and Anna Maria, for this really great insight into this very innovative program, and also the research that you're doing is very interesting. So first of all, I apologize to everyone because we're running so late. We started the second session late, and then our presenters have been great in being punctual, but we're still running late. So if anyone has to go, please feel free. I mean, I don't want to imprison you in this room, but for all those that are interested in asking some questions to our speakers, I would like to open the floor for a few minutes of Q&A. Is there anyone who has questions for our speakers? Yes. If you can introduce yourself, it's nicer so we know more about you.
I'm Sophie. I'm studying the postgraduate course at ITM at the moment. I have a very general question, so I'm not sure who to look at. In Europe lately, I think there's been sort of a political tendency towards right and far right governments, like in the Netherlands this morning. And I was wondering, in that context, how do you, as health workers and researchers, advocate for migrant health and migrant mental health in the very hostile contexts?
Is it for anyone or one of who feels strong enough? It's an answer that is very difficult.
Yeah, okay. I'm far from an advocacy expert, but from what I've seen my colleagues do in advocacy at Doctors Without Borders, we constantly advocate to governments, to agencies. I would say the last thing that came to my mind, and I think that is the most effective, is to plan some actions that have a negative let's say, effect on the position of the government. For example, last year, FEDASIL stopped the screening of medical and psychological screening. Therefore, MSF decided to install containers and resources that we usually have in other countries in front of Pacheco and do the screenings ourselves. And eventually, after 2-3 months of doing that, the program has been put back in place. So that's an example of actions that sometimes can be effective. Yeah.
Yeah, I saw also today the results of the election in Netherlands. Yeah, I think they surprised everyone, and we'll definitely see how the things will go on now. But before, what we did actually, and how also our program was born. So we did advocacy in the Tweede Kamer in the Parliament of Netherlands, and there was actually a motion of one of the parliament member about addressing actually the government. And stressing the importance of receiving mental health help in their own language. And to address this motion, government, they was obliged actually to do something. And that's actually how it was born. So the advocacy is hard. Always, and also our research and needs assessment helps a lot because we can show them some figures. And what we also did, we did the monitoring and evaluation of our program, so that also the part of our advocacy to show the results and how it also impact on the access and the well-being of Ukrainian displaced people.
Any more questions? Yeah, you have one to that.
I'm Lazar. In the different presentations that I liked, actually, I missed something about the follow-up of people you saw or you. So do you have an experience, you or Opora, or how do you experience the follow-up with your clients?
What do you mean by experience the follow-up? Yeah. So obviously in mental health work, the level of I don't know how you say it in English, people dropping off basically is always a little bit high. So it is higher. A short answer is it is difficult because when we talk about migrants, they're on the move, so therefore it's short-term therapy and follow-up. When it's asylum seekers, you see them and then suddenly they're being sent to a camp or to a center far away. So the follow-up are difficult, but what I would say is that, and I think that that's at least what I was trying to convey in a really short time, is that when you, and some of my colleagues as well, is that when you adapt your practices, when you take into account what other professionals say in that field, and you try to incorporate it in your practice, you see result, and I see result in my practice. I was not always doing my practice like that. I learned, like many people, to adapt myself, and I must say, when you start seeing those patients feeling better because of how you can just adapt a little bit more, it's so gratifying. And that's what I could say about your questions.
Oh, sorry.
Okay, my name is Koen van Praat. I'm a psychologist that does area care. At area care, we were in a different stage. The people are already settled, more or less, and will stay in Belgium. And the follow-up is built in the program. I knew from the beginning that I will see probably people or I get requests individually, and we have we will work on referrals, etc. It's a long-term program, and I think we will continue next year, maybe lower intensity. But it's something to be very aware of. If you start a project, mental health project, you will always need to think about the follow-up. So thank you for mentioning it.
We are already extremely late. I would just welcome you all to the reception that will take place downstairs, so you can keep chatting and networking with each other. And otherwise, I thank very much the speakers for the first and second session for a very, very interesting and thought-provoking work.
Want dat is nu. Heb ik nu weggedaan? Huh? Nee, niet uitzetten, maar... sorry. Terug naar de eerste deel. Hoe komen we daar terug? Ah, is goed. Okay. Ja? I think we do mensen ook.
Naar de eerste
maybe to be
the one practices of the advice, this one.